To be very brief, which is something I like doing anyway. But welcome everybody to the Wilson Center. My name is Gib Clark. I'm the coordinator of the Wilson Center's Global Health Initiative. It's really a thrill for us to be able to hold this event here and have all of you here, many of you coming from far and wide. I'll give you the brief info on the Wilson Center, since I think many of you are here for the first time. But essentially, this is a nonpartisan, non-advocacy center. It was founded by an act of Congress in 1968. It is the formal memorial to President Wilson, our 29th president, as he was our only president with a PhD, for better or for worse. The idea was to honor him by creating a center that brought together the worlds of policy with the worlds of practice. And that's what we and the 20 other programs here at the center aim to do with events, publications, and other activities here in Washington. Today is especially exciting for us, not only because of the subject and because of all the experts that will be speaking, but also because I'd just like to announce to all of you who are in D.C. or out of town as well, that we're going to be starting a maternal health policy dialogue series on December 3rd. This is being done with funding from the Maternal Health Task Force and the UNFPA, and with technical assistance and input from USAID. And so we're thankful to those partners, and we're thankful to all of you who will be coming to those events, and probably a lot of you who will be speaking at them. A couple of quick housekeeping notes before we get started. You'll see there are a few interpreters around the room, so don't be surprised if there's some whispering, and maybe you'll be doing some whispering yourselves. Also, there is no food or coffee allowed in this auditorium. We've just got it redone, refurbished. You're sitting on about 6-week-old chairs. I see some cups and some things like that. So if you've got it in here, slam it down. But please don't be bringing anything else in. Finally, before we get started, I'd just like to thank Emily Fritsch and Zoe Roof from PATH, who've been so helpful in putting all this together. Mary Ellen Stanton from USAID for making the introduction. And especially to Kaylin Ostrowski here at the Wilson Center, who's really handled pretty much everything involved in putting this event together on the Wilson Center side of things. So with that, I'd just like to turn things over to Lily, and thank you all for coming again, and look forward to a great day.
Thank you. Is this on?
Yes.
Okay. Hello, everyone. Good morning. I'm really delighted to see all of you here, and I want to welcome you all to POPPHI's End of Project. I can't believe it's End of Project already. And a special note of welcome to the government representatives from Bangladesh, Nepal, Mali, Ghana, and Guatemala. I want to begin by saying how much I have enjoyed working with the POPPHI team, how proud I am of their work, how privileged I feel to have been a part of it, and how it has been a journey of discovery for me personally. As a USAID manager of the POPPHI project, my priority has been to provide them with the support they needed and the freedom to fly. And did they fly? They spread their wings and soared. The POPPHI model was unique. It had a modest budget, but a big mandate. Its mandate was to coordinate and catalyze active management of the third stage of labor programs around the world. POPPHI's approach was multifaceted, either working directly or collaborating with partners on global policy and standards, national scale-up plans, logistics systems, research, and technology. It created the PPH working group that brought together global experts once a year, but pushed the agenda throughout the year. I won't go through the many accomplishments of the POPPHI project, because you will hear it directly from the implementers today. This is the little project that could, the tugboat that pulled big ships. The result was that of a catalytic force that has fostered a sea change. But POPPHI's achievements are not POPPHI's alone. Other partners have worked side by side with POPPHI, and we could not have done without their collaboration and partnership. I want to specially mention FIGO, ICM, WHO, host country governments, and USAID implementing partners, including Access, MCHIP, Africa 2010, Healthcare Improvement, Health Tech, Basics, and SPS. I hope I haven't missed anyone. We're grateful to all of you. Other valuable partners from whom we have learned much and have had complementary programs are Genuity and Venture Strategies. This special initiative was created many years ago, even before the POPPHI program started. The initiative was dreamed up by two very inspiring people who are sitting right here. One is Patricia Stevenson, another one is Mary Ellen Stanton. They dreamed up this initiative to focus on PPH many years before POPPHI was created. And it was first implemented by IntraHealth. And then it came to be known as POPPHI as a specific project. As POPPHI comes to an end, it is the close of one chapter, but we have already opened another new chapter under MCHIP, in which we will, MCHIP, by the way, is an acronym, Maternal Child Health Integrated Program, in which we will continue to focus on PPH prevention and treatment. POPPHI focus on prevention primarily, and now we're expanding it to include treatment. This laser-sharp focus on one intervention allowed us to understand this intervention much better. We have learned many lessons about this focused approach, and we have already begun replicating that focused approach for eclampsia. I want to thank the wonderful staff of POPPHI, Jeff Sine, who managed this project so ably, Sushi Engelbrecht. She's not here, is she?
No, we're sad about that.
Oh, that's really sad. She is a prolific trainer and a developer of job aids. Almost everything in that website that POPPHI has, she was the one who developed so many of those job aids. And if any of you have heard her laugh,
you wouldn't forget.
Her hearty laughter can bring sunshine into a dark room. Niamh Darcy, who calmly and politely badgered partners around the world for AMTSL data, proving that it is possible to increase AMTSL coverage rapidly if there is political commitment and technical support. Christina Kramer, who has quietly provided solid support to the project in so many ways. And Zoe Rolfe, Patricia Boysen, Emily Fritsch, who have been the backbone of the program. Let me end by expressing my very special thanks to two very passionate and inspiring leaders in this project, Deb Armbruster, for whom nothing is impossible, and Dr. Faisel from Engender Health Bangladesh, who engendered a national commitment for PPH prevention in partnership with the government of Bangladesh. Thank you.
Well, thanks, Lily. I really don't have anything left to say, so I should probably just go back to my seat after that. What can I say? On behalf of RTI International, it is my pleasure to say a few words nonetheless at this opening of the end of project meeting on the accomplishments of the POPPHI project and the way forward to continue addressing the many challenges that still lie ahead in the vitally important work that this project undertook over the past 5 years. We've been very proud to have been a part of this project's team of professionals who are so passionately committed to the cause of making pregnancy safer and who have been so effective at changing how the issue of postpartum hemorrhage is addressed, both at the policy level and vitally on the front lines of health services. As Lily pointed out, Deb has served tirelessly as the project director through the offices of our partner here at PATH, and her superb leadership has truly been, I think, the linchpin of POPPHI's success. We're grateful to her and her team at PATH, as well as to the other partners in gender health, the International Confederation of Midwives, and the International Federation of Obstetricians and Gynecologists, who are also critical partners that made this project so successful. We thank USAID for giving our partnership the opportunity, there you go. Everything is poppy now, to expand the knowledge of and use of AMTSL, an intervention with now proven capacity to reduce postpartum hemorrhage and save women's lives. It's truly impressive to have seen the impact that Deb, her team, and the many other partners have had across 40 countries. Niamh helped me to count those countries yesterday. A critical factor in POPPHI's success has been their ability to expand the partnership beyond our core team of institutional partners and to include many USAID country missions, international and local NGOs, and in fact many individual midwives, nurses, doctors, and public health professionals, some of whom have traveled quite far to be with us here today. By highlighting the power of this intervention, Deb and her expanded team have mobilized, energized, and inspired them to advocate for change far beyond the modest resources of this project itself. Their efforts have seeded the world to unleash the much greater potential this intervention has, and I look forward to today's opportunity to celebrate those achievements and to discuss where we all go from here. Thank you again.
And I just want to say welcome to all of the folks that have been part of the team, have been working for the last 4.5, 5 years on this effort. It's great to see everybody in one room, and I know we're still missing lots of people. I want to bring a welcome from Catherine Taylor. She's the MCHN head at PATH, and unfortunately wasn't able to be with us today. And since everybody else has spoken a lot about what we're up to here, I just want to, again, apologize for the time frame, how we're really going to be very strict about the time frame and the presentations, and apologize to those presenters who did send their presentations in early and we had to send back and say, too many slides, sorry about that, can you help us? And folks have been wonderful about really cutting important information down, so that's going to be important. The other thing we've done at the preeclampsia working group that was the last couple of days, they had the good fortune to give long, elaborate introductions to important people who do have many things to tell about them, but we've decided that what we're doing is really names and titles and organizations. So it's not that all of these people aren't important and have many things we could tell you about them, but that's how we're going to try to, again, cut back on and make sure we have enough time. One of the other things I want to say, let me tell you how much work this went into this. But one of the things, I hope you all get a chance to take a look at it, but as for all of the editing and the hard work we all put into it, there are going to be plenty of errors. People are going to come up to us and say, you forgot this here and you didn't say that right here, and why didn't you put me in here? So I want to apologize ahead of time. I have already found, Emily's going to have a heart attack, one fairly large error, and that is we all have the utmost respect for WHO, but I think there are many in the room who, there's a new statement that has come out about misoprostol, and we respect really the conservative, appropriately conservative nature of WHO and what they need to do, and they have put out a statement on misoprostol. Under the policy changes, I have said that we initiated, facilitated, supported, or advocated for some of the policies, giving credit to the people who made them, and we're happy to have supported those efforts, but I must say that's one particular statement that got in here that we didn't support. So please be careful when you read this. So that's the one error that I did find in here, and I'm not quite sure how we did that. Lastly, before we move on, I want these folks to stand up. There's somebody that Lily didn't mention, but has been with us for a while. She had Patricia Boyson's name, who was with us earlier. Sarah Pretty has also been an administrator. She's been working with us, and nobody could be better on an end of project. So I want all of these people to stand up, and I want to give them a big round of applause. as you all know, without them, none of this would have happened, and none of the work that's gone on in POPPHI would have happened. So they've been an amazing team, and nobody should get any ideas about trying to steal them because we're going to keep them. So thank you. And I do want to say particularly Christina has, in addition to what Lily said, she has really, over the last year, since we've had a new project, been really helping with kind of co-directing and making sure we could get everything done. And with that, I think we'll begin. I think I'm first, too. Intimidating. Okay, we're going to start with scale up and impact. How far have we, POPPHI, and really all of you, come, and where to next? First, I wanted to talk a little bit about scaling up, and kind of I actually spent a little time earlier looking up what are the definitions of this. This is kind of a funny definition, but I felt like it really captured what we were after, which is efforts to bring more quality benefits to more people over a wider geographic area, more quickly and more equitably and more lastingly, which is a very strange word, but we have to give the International Institute of Rural Construction credit for that. So POPPHI was really trying to scale up. And I want to right off the bat say, if that's what we're going to be measured against, I don't think we were successful in any particular country. I think what we've been able to scale up is that, as I don't know if it was Matthews was saying it and somebody else was saying it, around the world, I do think people now know what active management is. I don't think it's important that they know the word POPPHI, but what it's about is that they understand that this is an important intervention, that we have been scaling up the knowledge and skills needed, though I don't think we've had the time or the money to really ensure that we have any country per se that's really scaled up. But let's look at what are the different types of scale-up strategies that are possible. We've got quantitative, which increases the beneficiaries, the functional, which is the interventions, the political scale-up, which I kind of call policy and advocacy and addressing barriers, and the organizational scale-up, which is let's add more numbers to the numbers of organizations or improve our own ability to do so. I want to start with, this is actually a slide from Lily. Actually, it should be Nilly because it's Niamh and Lily put this together. I think if you look down the left side here, you all are going to see yourselves. And I don't want to start listing organizations because I will forget somebody. But this country data, these are the USAID projects. And they're various organizations, quite a number of them, that have worked across 16 countries, 640,000 vaginal deliveries, and have brought AMTSL rates up to 90%. And I think what this says is that if you work hard at it, it's quite scalable. And this is the kind of the joint effort that I think we've been able to do. And we do call Niamh a badger because, and I think all of the people around here know this, she comes calling for data. And this is what we've been able to do and assist AID in pulling this data together of all the work that's being done, or as much as we can collect on active management of the third stage of labor. Functional scale-up. So one of the things POPPHI has done is try to identify mechanisms, whether they're training mechanisms, other things that will help in scale-up. One of my favorites, but there are many favorites, is Cambio. We give Pierre Buchan's credit for the name, but it's really taking the work of Fernando Altabe, Ezequiel Garcia Lorio, and that whole team. So it's Tulane as part of it. Their research from the NIH study on how can you increase the use of evidence-based practice, and they did it in Argentina and took AMTSL from, I think it was just the AMTSL, from 4% to 67, well, a total of 67% increase. We have then taken it and put it together in a program package, and we haven't had really enough time, but we've been working hard in Ghana to implement it in teaching hospitals. the important thing, I think there's two important things. One, it's a new way, rather inexpensive, but also it's trying to address teaching hospitals, which nobody else wants to touch. The other one is the SANE training. This is one of Sushi's specialties, combining self-directed learning or self-paced with really a district strategy of kind of upgrading, creating a team in the district hospital who then work with the peripheral providers. We did it in Mali and in Ghana, so it's the midwives. We found that we could train 81 providers in 3 months for half the cost of training. I think Dr. Asari will also mention this when she talks about what's happening in Ghana. The immediate postpartum care package, I was also very excited about this one. This is really, and I think we have Indira here, who's with Basics, worked with Sushi, and they created an AMTSL newborn. So it's, with the birth of the baby, let's take care of the baby and let's take care of the mother at the same time. In Indonesia, I have to admit, we didn't get as far as we wanted with the National Plan of Action on PPH Prevention. And I would say Engender Health has had a national task force on PPH prevention. I think that's an activity as well that could be used to scale up. We've got pilot projects on misoprostol. I think, encouraged Ventures to work with Bangladesh and assist there. Ventures is also, we've been working with Jeanette in Ghana, trying to get the misoprostol pilots going, and there have been a number of other ones going on. Oxytocin and Uniject, Mali, quite successful there, and we have a current one going on in Guatemala, which we'll hear about later. The collaborative work is another model. I think that's really URC and the Quality Improvement Project, and now the Healthcare Improvement Project in Niger, Central America. And I do think we need to realize that reporting and data collection is a powerful tool to use to actually get providers to realize the importance and to understand when it's happening and when it isn't. I didn't put down a description, but I saw Stacy Geller here today. I think she and Sue Ellen Miller came up with the continuum of care concept, and Pathfinder is moving it forward now in a number of countries. So lots of ways to do this, and we've helped promote, share, etc., these different ways. So political. I do think this is our most important contribution. I think we've added momentum, and here's where, I can't emphasize this enough. We added momentum to others' work. WHO already had leadership on this. There was already statements, and it was in impact. ICM and FIGO had just created the new joint statement, the first joint statement on AMTSL. USAID had made it a priority and was really encouraging all the projects to use it, and really wanted to get it as an indicator. And even NICHD and of NIH was doing research on it. And we have Richard Derman here with the seminal study from Belgium that helped us understand what misoprostol could do. So we established evidence to create a consistent message on active management. We showed that it could have large impact and that it was doable. We gave policymakers, I always think about it, something to wrap their hands around. I think I never had trouble convincing people that this was something they could do, that they could take it on, they could see what the possibilities were. And I'm not sure how we kind of started out with our AMTSL survey, but we've certainly found, and we continue to see the impact of that. And we do have Cindy, who's going to talk later about some other work here. And she's just starting to understand the importance of this. But we collected data, determined the reality on the ground, identified barriers, and engaged in-country stakeholders to understand their reality. And really, we always had, oh my heavens, you're kidding. We only have that? We're only doing that? And then a real look at what do you do next. So lots of people have seen this slide. This is a little different here. This, again, was put in a way that Lily was using it. But I think what it showed us that we really did have low coverage. While everybody around the world said, active management, we're doing that, not a problem. We were able to say, well, really? I don't think so. And have people take a look at what they could do. We created a forum for sharing data on misoprostol. We supported the dissemination of data and got to go to Gao in India for the big meeting. For the seminal RCT in Belgaum, India, developed strategies. And I should say, and I'm sorry, Januti, I should have put it up here. We've sponsored a couple of meetings to share their data because Januti has had some wonderful studies, and we've been able to share their data with, all of our colleagues. developed strategies and advocated for community-based strategies for PPH prevention through some of our task force and our working group. Supported the development and dissemination of ICM-FIGO's second joint statement, which was on PPH prevention in low-resource settings, and then supported putting a letter to WHO together to support getting it on the essential medicine list. And unfortunately, Honduras, it's too bad they're not here. We have exciting things planned for Honduras, but I think it will be things that move into MCHIP. We worked with professional associations. We had meetings with 24 of them and gave grants to 16. Partnered, and I will say Access had a wonderful, they were the lead on the Entebbe workshop, which brought lots of folks together and really motivated a lot of countries to work on PPH prevention. And then we were lucky to host one in Latin America, which I think also really kind of pushed the envelope and brought folks together to talk about this issue. And in the booklet I was showing you, there's a long list of the different policies that have changed over the time POPPHI's been here. We don't take credit for any of them, but we feel we've helped initiate, facilitate, support, advocate for many of the global and regional policy changes that have occurred over the last 5 years. I hope you can, this has been a struggle to try to get this visible, but the only point is, as Jeff said, you know, what countries have we actually had some kind of impact in? And I think this is 40 countries that have really worked on active management in one way or another, everything from Iraq. I mean, we actually, Sushi in particular, but we worked with an army captain, I think it was, who wanted to do a training in the hospital in Iraq, and we facilitated that. I got a call, or I got an email last week from Comoros. Now, Comoros didn't make it on the map, but you know, the website has really given people a place to look to see what they can do. So I think we have a footprint in at least 40 countries that we've left and initiated things. We've encouraged other organizations to participate in the PPH prevention work, join task forces, be in the big working group, and especially to provide your in-country data to us. So support, guidance, technical updates, materials, websites, listservs, and just getting more people and more organizations involved. Really seeing that, you know, as a small project, the best thing we could do is kind of widen the scope and bring everybody into the fold. Okay, so what actually should influence the success of scaling up? You need adequate funding for at least 10 years. I didn't make these up, by the way. I got them out of a book. There should be political leadership and champions to ensure visible high-level commitment and maintain vision of scale. There should be existing systems used and adapted to introduce the project technologies at a sustainable price. Technical consensus around the biomedical or public health approach, good management to maintain quality in the project, and effective use of information. This is what we think we've been able to do. Really, you know, support political leadership, identify the champions. I think we've been very lucky, and it probably would be a big lesson learned. Keep it simple and have consensus. That, I think, has helped tremendously to get the word out on active management in particular, and effectively use the information that we have for action. What about impact? So it's a strong effect, it influences strongly, and it has a forceful consequence. We created this early on. There's a number of people involved in this. Cindy Stanton has to get the original credit. As we tried to put AMTSL's survey together, we tried to identify these components that we would need to collect data on. And then Lily, Sushi, Niamh all got together to create, I think Lily simplified our original set. But I think it's proved very useful to look at what are the elements of active management that we need to work on, because then you can break it down and focus. So we've got our policy, our provider practice, our logistics, the drugs and supplies, and the monitoring and supervision. So in policy, what we have been able to do that I think has had impact is update the definitions of active management. I mean, it had happened with the joint statement, so we were promoting that, and it removed the immediate cord clamping. I think we advocated, and Matthews is here. Matthews takes, I think, a lot of responsibility for getting the delayed cord clamping actually into WHO's recommendations. I think we've got a long way to go to ensure that happens. Many people have told me It's not happening when you're in the field. So I think we have a long way to go, but you need the recommendation to begin. I think the addition of massage and the surveillance has really opened people's eyes. Dr. Asari, I remember when we did the dissemination meeting in Ghana, the one thing she said, that's our problem. We're not looking at these women after birth. We're not, we may do the oxytocin, we may do the controlled cord traction, but then we leave them, and we really need to work on that. We brought together the USP, United States Pharmacopoeia. Hans Hogerziel came. I'll talk a little bit about this later, but ultimately we changed the oxytocin storage requirements and really hopefully are starting to help people understand oxytocin isn't as temperature labile as everybody thinks it is. The delayed cord clamping we said, and we supported it's the technical consultation in 2006 on the recommendations for PPH prevention, where WHO said all women should receive a uterotonic, and that's even when they don't get AMTSL through a skilled birth attendant, and that oxytocin and misoprostol can be used. So we'll go quickly through this. We actually did our own little mini survey to find out who's made changes in policy. You can see Benin, Mali, Ukraine, Bangladesh, Ghana, DRC, long list of countries, and we know it's not everyone that we were able to collect the data on, who changed policy to support community-based PPH prevention. Bangladesh and Ghana, and oxytocin as the drug of choice. Malawi, East Africa, and I think some in West Africa too, had ergometrine as the kind of primary drug of choice in the peripheral clinics, and they switched to oxytocin because we know ergometrine really has heat stability problems. And misoprostol has gotten onto the EML in 14 countries, and this is Venture's data, VSI's data, I learned. We helped or facilitated or know about standardized in-service training programs are available in all these countries. We integrated AMTSL into pre-service education programs in these countries, or assisted, or sometimes we're just collecting data on the work of some of you. This is some of our latest data. We were lucky enough to be able to repeat 2 of the surveys. Ghana started out at 3% of practicing active management. We have a 9-fold increase only to 27%. Long way to go, but it's, it's, as Gloria said, the commitment's there. They'll get there. Indonesia, I just received the data from Iwan. They've also repeated the survey. Again, I think the folks who've been working in Indonesia, we got I wouldn't say blockaded. We were not able to do as much work as we had hoped with that national action plan. So to be honest, I think the majority of this increase is things that the USAID bilateral has done, or the dissemination of the results and the heads up to all of the hospitals that were a part of it to make some changes, I think had a big part of this. So Indonesia went from 31 to 40%. We've created tools. I think it was Matthews who said, I see these posters everywhere. And we're very pleased. I saw them. We did a surprise visit up in, I think it was Jenne in Mali. And sure enough, there they were in the labor wards in French. And the website, I think, has also been a powerful tool. And we've really worked on innovative ways. So many of you have wonderful training programs. But we were really tasked with, what else can you do? How could you be innovative? How can we increase it with less expense? And we've been trying. For the drugs and logistics, we started by highlighting the inconsistencies in the messages about oxytocin. It only had been 5 years before when in the U.S., oxytocin was kept at room temperature. It was not refrigerated. So that gave me a heads up. Something's going on here. So that's when we had a big meeting with WHO. Matthew's first foray into coming to one of our meetings. We had Hans Hogerziel and the experts from USAID. And we brought up the evidence that had been, I think it's 1993 evidence, but nobody was using it because we were certainly hearing in the field nobody knew ergometrine was supposed to be refrigerated. We got USP to update their monograph on oxytocin. They basically changed it from the need for refrigeration to using the stability data, which often says room temperature, that the company presented. We actually had one of the companies change their storage requirements and change it to the 15 to 25 or room temperature. We partnered, and this was a really strong partnership, and I really have appreciated working with kind of our colleagues that work in the drug line, because we often don't link up with, the public health people and the pharmacy people don't talk. So we don't realize why we don't have the drugs or why they're not being taken care of properly. And so we have really enjoyed working with RPM Plus, and I think Grace today is going to talk about a survey they did in 5 countries, really trying to strengthen the uteronic drug system. We have guidelines, and again, this is some of Sushi worked with the MSH folks to create this. This is a storage audiovisual, and linked the CMSs and the pharmacies with clinicians and public health literature, and initiated some lit reviews and expert meetings on induction augmentation. That's kind of our foray into realizing we need to be thinking about that as well. And I think that's an important area we need to be looking at next. We've had many different ways people monitored and evaluated and collected information on use of active management and use of misoprostol as well. And so this kind of goes through the different ways, using the partograph with all of the components, just checking it on the partograph, delivery records. The medical records are modified. I know in Ghana, in Korlibu, they're using the chart. They actually put it in the chart. There's a couple of countries, and we were excited. Senegal has actually gotten it into the HMIS, the national HMIS, and Honduras. The 3 different components, and that the AMTSL protocol has been added to supervision tools, and you can see where that's happened. So this is a very recent acronym I've come up with. I think it was for the breakfast meeting yesterday. And so I feel like, in summary, what we've been able to do is to build on the evidence, the WHO support, the ICM-FIGO joint statements, and momentum of the work that's gone on. We've obtained consensus on messages and made it easy for others to join this effort. We've linked partners, identified collaborators, and created win-win situations for everybody to work together. And we've helped show that it's doable, that we help policymakers and program managers see that AMTSL and PPH prevention could be accomplished and have impact. So where to next? I think a lot of you may have as many ideas and maybe more than I have, but I think we need to continue the momentum, and I do think Harshad said this well at our last PPH working group. Build on the successes, learn from our challenges, and expand the effort. And I think we really need, and I would really like to see some real focused country efforts, and put the countries need to identify it themselves where there's the political will and the champions to truly scale up, and we need to help them with that. And the last one is for Mary Ellen, because she has said, as I think Richard Green keeps saying, we've really got to be able to measure the impact. We've got to show what this does. We just finished a meeting with WHO on indicators. Very interesting meeting with the HMIS people. And so that's something, it's not there, but we need to keep going on. Can we identifying a global indicator for PPH prevention? So I think we need to have a joint statement. We've been working with WHO. We're not there yet. Luke is here too from UNFPA, a joint statement on active management. But not just the joint statement, a real push out to the field offices and strong encouragement that they use this and ensure that it's included in country programs. We didn't see the ICM and FIGO, and particularly ICM, worked on physiologic management. I think the final decision is that ICM and FIGO want to roll this into one statement instead of multiple joint statements. But I think a number of midwives around the world have really felt it's important that we don't lose this where we don't have drugs, so that we don't have people doing controlled cord traction when they don't have oxytocin. So again, I think it's an important contribution to the effort. Misoprostol, that we use the Genuity Pakistan data or complete the needed research to end the controversy and make it available. That we do more work on induction and augmentation guidelines for low resource settings. That for providers, share and evaluate models to expand coverage, straight under drugs and logistics, develop stronger partnerships with central medical stores, pharmacy boards, to strengthen the systems of delivery and storage. I would strongly suggest to expand the use of oxytocin and Uniject for lots of reasons, and to complete the research on thermostable oxytocin, which the Dutch government is doing, and that we actually have a WHO indicator integrated into the HMIS. Thank you. In the interest of time, I think maybe one question, but then I think we need to move on, or clarification, because we'll have time and lots of other things going on throughout the day. I thank you very much for no questions. That's good. Okay, could we have the next panel come forward, please?